Okay, so welcome to the next module. Here we're going to be talking about DeQuervain's tenosynovitis. It's not going to be super in-depth like the other modules, more so a fundamental crash course, kind of going over what it is, kind of refamiliarize yourself with it, and just kind of get the ball rolling when it comes to transitioning from going from an academic setting into a clinical one. So what we'll cover again, so what it is, how does it occur, the signs and symptoms that you'll usually see with the patient when they come to see you, the anatomy and physiology behind these signs and symptoms, what to consider during an evaluation, and then also what to consider potentially during treatment sessions. So first and foremost is the what and how. So DeQuervain's tenosynovitis is a painful condition affecting the tendons on the thumb side of the wrist, so on like the radial aspect of the wrist. So more specifically, the APL and the EPB often involves inflammation and thickening of the tendon sheath around them, leading to pain, swelling, and difficulty with thumb and wrist movements. So again, that APL, EPB kind of going in the thumb side, making that first dorsal compartment. How it often occurs. So one of the most common, or maybe just very common scenarios where patients come in with this condition is new parents or caregivers. So the act of like repeatedly lifting a baby, especially with the wrist in a bent position or the thumb extended, can strain the tendons, leading to what is called often mommy's thumb. So recognizing these everyday contributing factors is important, especially when it comes to educating these patients and developing treatment plans that will create long-lasting therapeutic improvements. Um, Other activities, so like lifting, gripping, texting, ringing motions can contribute to the irritation and overuse of these tendons, but just know that these two are usually the culprits. So going into signs and symptoms, so how are these patients feeling and what are their functional limitations? So when working with patients who have DeQuervain's, you'll often notice that there's reported pain and tenderness over the thumb side of the wrist, particularly again over the first dorsal compartment where the affected tendons run. Um, I'll go over the first dorsal compartment a little later on in this presentation a bit more, but essentially swelling in this area is very common, and there might also be some subtle like grating or clicking sensations too when the thumb and wrist is moving, and this is often described as crepitus. This happens because the inflamed tendons in their sheaths rub against each other as they pass through the tight tunnel, causing that rough sensation and producing that feeling and sometimes sound. Patients will often report increased pain with movements that involve the thumb or wrist, like gripping and twisting. And then lastly, I'll note that patients will often have a positive Finkelstein's test when assessed. And I'll go over this evaluation portion later in the presentation. But some of those functional limitations, again, gripping and pinching, pain with lifting objects, reduced thumb range of motion and strength, and then reduced fine motor ability as well. Um, so let's move on to the A and P aspect of that. So anatomically, what's affected and what is occurring. So here on this image, we got the first dorsal compartment running on that right side of the wrist. Culprits again, APL and the EPB. Keep in mind inflammation, irritation, the thickening of the sheath, reduced gliding, all comes into play here. So the image highlights the structures involved. You can see the APL and the EPB going through that first dorsal compartment, sort of here in that little like pocket almost. Um, and notice again that this isn't really a very large space at all for these tendons to be moving through. So with added irritation and inflammation, you get a similar situation as you do with carpal tunnel syndrome, where the space becomes too tight due to inflammation and causes physical irritation and discomfort with related movements. And these structures can become compressed between the extensor retinaculum and the radial styloid. I will show some more images here in a bit. But feel free to even look up more on your own if you have any like A and P resources. Kind of zoom in on this guy, perhaps if you have Visibody. But thinking about the APL and the EPB and their specific muscle actions in terms of what movements they help produce. So thumb abduction and extension, and then wrist radial deviation and even flexion can all be movements that are affected and cause pain and discomfort due to the inflammation and compression of these two muscle tendons. The thickening of these sheaths over these muscle tendons can ultimately affect the smooth gliding when performing wrist and thumb movements, which is like the root cause of the pain experienced and the limited range of motion that the patient can be experiencing as well. So let's take a look real quick at the extensor retinaculum. No need to pay attention to the label of Lister's tubercle here. This is just kind of like one of the better images that I found here. But what I want you to notice from this image is like the wrap-like structure moving horizontally. This is the extensor retinaculum that's found on the dorsal side of the wrist. The structure helps formulate the six different dorsal compartments. You can follow those dotted lines down below and see and trace each labeled compartment, but we'll, in this instance, only focus on number one, which is the first dorsal compartment, again, where the APL, so the abductor pollicis longus, and then the EPB, the extensor pollicis brevis, travel through. This is palpable. You can do this by kind of performing thumb extension and putting your, like, let's say, like right now, for example, I'm putting my left thumb on the right side of my right wrist, kind of over that radial styloid. And then I can perform thumb extension and I can feel some of those tendons tightening. And that's where you'll start feeling that first dorsal compartment. I'll also want to state um, that this will be like a very useful way to kind of differentiate and identify the culprit in this instance when you have a patient. So I'll apply another video along with this for palpation specifically, since you can't see me right now. But let's go into the evaluation aspect. So, like with any evaluation, you'll always begin seeking subjective information and listen to the patient what brings them into the therapy clinic. You want to get an understanding of what's bothering them. So, what the pain or irritation is like, where is it occurring, what is causing it, what alleviates it, and what do they do on a day-to-day basis for home life and, if applicable, work life to gain an understanding of their functional demands and what might also trigger the pain discomfort. Oftentimes, you might feel yourself kind of playing detective in a case, and they'll start telling you about things that they're doing. Um, and you might have a light bulb switch as to this might be causing the pain, or this might be the culprit, or these are things that we could change to alleviate some of those pains and symptoms. But when the patient, and if the patient is reporting radial sided pain on the wrist, you can suspect the tendons on the first dorsal compartment. Then you can begin to palpate the area over the radial styloid and assess if it feels or seems to be inflamed. It might even note that the palpation can reproduce symptoms for the patient and be uncomfortable and can be an uncomfortable experience due to the pain triggered. You can also approach the assessment by performing the Finkelstein's test, where the patient is asked to actively place pressure on the APL and EPB to assess if the root cause of the pain and the functional decline of the patient is this, like specifically. Um, and the next slide will be like dedicated to this test. Strength testing and grip strength testing can be performed bilaterally to assess deficits in strength and further support any declines in function. You'll also want to perform active range of motion measurements for the thumb and the wrist bilaterally for comparison. Remember what the functions of the APL and EPB are to get an idea of what functional deficit they may have reported to influence what measures you would like to take during your evaluation, and use it for tracking progress in therapy. Next, even splinting can be a very useful tool in helping the patient gain relief from these tendons and allow them to participate actively in their daily lives a bit more without those painful symptoms of the condition. I'll also go over splinting and taping in the treatment section of this presentation. And then lastly, an HEP. So you'll discuss and assess appropriate introductory exercises for your patient that will help with their condition between therapy visits and activities to help avoid that will allow for proper healing to the muscle tendons and surrounding tissue. This will essentially be some introductory exercises for them to stretch the affected tendons without increased irritation, massaging the relevant muscle tissue and promote circulation, maintaining functional use of the affected hand without triggering symptoms. And so this can be done by avoiding repetitive pinching activities within the wrist, especially in flexion, avoiding prolonged ulnar deviation, and any other functional considerations and adaptations that may have been discussed during the eval to implement in their daily lives as you see fit. So again, as I said, the next slide dedicated to Finkelstein's testing. So essentially, the test is pretty straightforward and it's easy to administer. It's one that's very useful in understanding if your patient is experiencing inflammation and irritation of the APL and EPB muscle tendons. Essentially, the patient is asked to hold their thumb in their palm, and then with their fingers forming kind of like a tight grip, and then ask them to bring the wrist down as they're performing a hammering movement with their wrist. If the patient is experiencing irritation in the muscle tendons traveling through the first dorsal compartment, then this test will often reproduce painful symptoms. And this is because the test itself purposefully places the APL and the EPB tendons in a stretch in the confined dorsal compartment, and the tendons experience increased resistance due to the swelling and inflammation, causing a sharp, localized pain over the radial styloid on the thumb side of the wrist. So let's briefly look into treatment. So again, just breaking the ice here. So orthotics and taping. So the image on the left is a custom orthosis that was made to help promote healing in a patient with DeQuervain's, often referred to as the thumb spica. You can see that this immobilizes the wrist joint as well as the thumb MP joint, but leaves the thumb IP joint free. This is especially important because it's a crucial joint in opposition tasks. And if you were to block that off, you might find that your patient will not be wearing that splint very often because it'll be too difficult for them to use their affected hand. So having this IP joint free allows them to use their hand and still get the benefits of the splint from healing, rather than just kind of confining them and then feeling like, well, I can't do anything with my right or left hand, depending on which is affected. So kind of freeing up the joints that aren't causing any irritation or aren't the culprits will allow them to ultimately encourage them to wear it more. Another thing I would like to note is how large this billet may seem. This can be a preference really, but in the image they're using a forearm-based wrist hand splint, but I know that it can be a bit smaller based on what you're kind of shooting for. This will be a preference thing. You'll find what works for you, what the patient likes the most, but oftentimes the prefab splints will resemble the one you see on the screen, and they're again kind of like a one size fits most. But I found in the clinical setting, my clinical instructor would often make these custom for the patients, and they would be a lot smaller than this. The second image is an example of DeQuervain's taping that you can do to help alleviate symptoms. It's a lot less bulky than wearing a splint, but it does not offer that immobilization aspect that may be useful in the beginning weeks of experiencing these symptoms and coming into the clinic as a patient. So while there are multiple ways of taping for different conditions and symptoms, know that there isn't specifically a right or wrong way when it comes to doing this. Ultimately, you'll have the chance to experience what works for some patients, what doesn't work for others, what you prefer to use, the expertise from your clinical instructors, and that will kind of guide you in terms of which you'll probably lean towards when treating patients. And so to briefly talk about this taping, they're essentially two strips of K-tape that are applied over one along the APL and the EPB with them in stretch first. So you're anchoring down distally on the thumb and then having some stretch into the muscle bellies in the forearm. And then there's an anchor piece that also goes perpendicular to the first tape strip along the wrist, kind of holding that down. There will be a really good video attached to kind of follow along. You can definitely practice and do it on yourself. I've done it many times. It's kind of fun, but if you have access to it, I definitely encourage it. And then lastly, let's quickly talk about intervention. So with intervention, again, this is not an in-depth list of everything that you can or should do. Instead, this is more to kind of, again, get that ball rolling, encourage you to think about the anatomy, think about what the patient's functional life and their demands are, consider tissue healing principles to clinically challenge yourself to go the extra mile and think about what will help reduce painful symptoms and what will help them achieve their functional goals from a therapy perspective. Also, while using the equipment you have available within your clinic. So these are not in any particular order, but let's just kind of start at the top. So activity modification can be an important component of treatment as you'll be aiming to reduce pain so that they can participate actively in their daily lives. So avoiding specific movements that initially trigger pain can be very useful. Avoiding prolonged wrist flexion and ulnar deviation. Avoiding repetitive pinching movements and wrist movements, and even participating in some ergonomic changes such as using an ergonomic keyboard or a mouse that promotes a more neutral and natural position of the wrist and hand. Also, using and wearing an orthosis early on can be useful to help place the wrist and thumb in a position that allows for proper healing. Again, being a bit of that MP joint flexion, about like 10 degrees, and the wrist in about 10 and 15 degrees of extension, but maintaining that mobile thumb IP joint that allows for functional use of the hand while you're wearing that orthosis. Next, soft tissue massaging can be a very useful tool as well as your physical agent modalities. So therapeutic ultrasound has its own tissue healing and heating benefits, but note that if they received recent like cortisone injections for their pain, this is actually contraindicated and you should stay away from it for a certain amount of time. The heat and mechanics behind the ultrasound essentially can increase local circulation more than we would want it to and potentially disperse the medication too quickly. So there's a time frame where you would prefer to wait after cortisone injections. I honestly don't know it off the top of my head, but I can definitely plug it into this module quickly. But soft tissue massaging and instrument-assisted soft tissue massaging can be useful when applied to the APL and EPB muscles, APL and EPB muscles, sorry, to reduce that tension, break down any potential adhesions, reduce pain, and it can be a great prep prior to activity along with heat. Stretching can be useful as well. This will be at the pace of the patient's pain, as you won't want to exceed more than like 3 or 4 out of 10 pain. So stretching the APB and the EPL muscles will be useful to promote that proper gliding through the compartment as inflammation and irritation is being brought down throughout visits. Specific DeQuervain's stretches and glides can be utilized as well as various thumb flexion, lifts, and retropulsion exercises can be useful. Strengthening can be used later on as the patient is experiencing less pain to enhance and maintain muscle balance in the affected area. So you'll want to restore some functional thumb stability, decrease the chances of reoccurrence, and allow for more functional integration. You can do various resisted thumb exercises too with like sponges or bands or providing isometric contractions. So you can kind of like have them perform like the motion of the Finkelsteins and add some resistance, either feeling less pain to help strengthen those tendons there. And then lastly, I would like to add that you shouldn't forget about functional activities. Think about their demands and their daily activities and consider activities that can be fun to them and relevant. So things that I would like to know is like various fine motor tasks, especially those that include the thumb, such as opposition tasks can be super useful in a therapy setting. But essentially, that is the quick crash course. I'll have other resources in the module for you to look over and kind of spread out the learning and kind of give you a bit more of a chance to give yourself the ability to run into some rabbit holes if you'd like to, but also see some videos that are interactive so that you can kind of follow along. And hopefully, this won't be a novelty to you when it comes to treating future patients with DeQuervain's tenosynovitis. But again, thank you for listening, and I look forward to the next module.